In Chapter 21, we will be going over the thorax and abdomen. The thorax of the body includes the area that is encased by the ribs, and it includes the chest and sternum all through here. So that's what we refer to as the thorax. The muscles in the thorax and abdomen are the transverse abdominis, which is the abdominal muscle that's deep inside. The fibers run this way, side to side. It's our deepest abdominal muscle. Its job is basically to hold the guts in, but because of its positioning and because it does attach to the spine, it is also considered to be a spinal stabilizer. We also have our internal oblique muscle, which is our next oblique. So this one has fibers that run up like this. And so when those shorten, they'll help to twist the trunk or rotate the trunk. And then we also have an external oblique, with fibers that run down. So the external oblique fibers run down. So they also help to twist the trunk. And we also have our rectus abdominis, which is our six-pack muscle here on the front, or eight-pack if you're really ripped, I guess. And that helps to flex the trunk. So I don't talk about the rectus abdominis a ton because it's not really super helpful with spinal stabilization, but obviously, like, you want to be able to flex your trunk. You want all of your muscles to be well conditioned and strong. So it's not a bad muscle. It's just not really protective for the back, which is why I haven't discussed it a whole lot up till now. As far as the bones in our thorax and abdomen, we have our sternum. This is in our chest. So this is all a part of the sternum coming through here, and including our little tail here on the bottom. So the top here is the manubrium. So that's the name of the top of the sternum. This middle part is the body. And this little part at the end is called the xiphoid process. It's actually somewhat easy to damage the xiphoid process if we get elbowed in the rib cage right there, or fall on a ball or something to that effect. If your hand position isn't proper with CPR, you could also fracture that. As far as the thorax go, we have ribs 1 through 12. So rib 1 is actually pretty high here. It is tucked up right under the clavicle. Then we have 2, 3, 4, 5, 6, 7, and then 8, 9, 10, 11, 12. So those last two are actually not attached to the sternum in any way. We call them floating ribs. But in the back, these ribs are attached to the thoracic vertebrae. So there are 12 ribs, 12 thoracic vertebrae. In the front, for the most part, they attach to the sternum and the rib cage. Some of these we call true ribs because they do have a direct attachment to the sternum. But some of the others are only attached through long pieces of cartilage down here. And we would consider those more to be what we call false ribs. So they're not completely attached to the sternum. In our abdomen, we have a lot of internal organs. So in our thorax, we have our heart and our lungs and things like that. But in terms of our abdomen, that's where the majority of our internal organs live. So when we're checking when we're palpating the person, we start in the right upper quadrant. So in the right upper quadrant, we're going to have the liver. So the majority of the liver is here in the right upper quadrant, although part of it goes into the left upper quadrant as well. We also have the gallbladder, which is kind of deeper inside, and the pancreas, which are deeper inside in that general region. Then working our way around, we have intestines throughout the middle of the stomach. That's more the small intestine. The large intestine kind of makes a loop. and then our spleen is on this side, tucked up under the ribs. Our stomach is also in the middle, kind of higher up though. So our stomach would be, again, tucked up somewhat kind of under the ribs here. And our bladder is down low, kind of tucked up under the pubic bone for the most part. So as far as function of these organs, our liver's job is to filter toxins. It is solid and it may get injured in sport. Our gallbladder aids in digestion and it's also solid. Pancreas aids in digestion, also solid. The spleen makes red blood cells. It's solid and it's easily ruptured in sports. The kidneys filter toxins. They're solid and they may be injured in sports. We might see blood in the urine. You can't see the kidneys in this picture as well because the kidneys are so deep inside. So we see the kidneys better in this picture back here. So this is where we've actually kind of taken out all the intestines so that we can see deeper into the abdomen. So the kidneys are actually more towards the back. Our stomach is in charge of digestion and it's hollow. Our large and small intestine are also in charge of digestion and they're hollow. And the bladder stores urine and it's hollow. Now, those organs that are often injured in sport are bold here. I put them in bold. The main thing that you will see that is similar about these is that they are all solid organs. Excuse me. And the other thing that's interesting about these is that they're all somewhat closer to the surface. So the liver kind of peeks out under the bottom of the rib cage, and the spleen is mostly under the rib cage, but the person extends their body or twists, or if they have an enlarged spleen, then that can kind of peek out from below the rib cage. And then the kidneys are closer to the surface in the posterior side of the body. So all of those are solid organs that are somewhat near the surface or the perimeter of the body. So with the hollow organs, usually if you get hit in a hollow organ and it's empty, nothing happens. It just smushes. It's like a half full balloon. Nothing. It's fine and nothing happens. But with the solid organs, the big compression or a big blow can cause what we call a laceration, and that can cause damage. And depending on the organ, it can cause a lot of pain, discomfort, and it could be an emergency. But with the hollow organs, as long as they're empty, they just kind of smush and it's hard to injure them. As far as preventing injuries to the thorax and abdomen, we want to make sure we're using appropriate protective equipment. So this is really important for collision sports. So the shoulder pads are somewhat protective as far as the sternum goes. Sometimes when somebody has had previous rib injuries, they'll wear rib padding like this. So that's more of a pad. In football, they also have what they call a flak jacket, which is padded on the inside like this, and then there's a hard covering on the outside. So you'll see these often in quarterbacks or receivers who've been injured in the ribs previously. This little pull-on shirt might go on under the flak jacket, or this might be something more appropriate for rugby or another sport like that. Having appropriate strength in the abdominal musculature will protect underlying organs as well. And a really big thing is make sure hollow organs are empty prior to competition. Generally speaking, people want to go to the bathroom before they play just because they feel lighter or they feel like they're not worried about having to go to the bathroom while they're trying to compete. But realistically, it does help to prevent injury as well. If the bladder's full and you get struck in the bladder, you could rupture your bladder, but it's not very common. So we want to empty, we want to basically go to the bathroom, go pee, go poop if you have to, that kind of thing. It's going to reduce the chance of injury. As far as assessment of the thorax and abdomen, injuries to this region can produce life-threatening situations, so we want to take these seriously and make sure that we're clearing any of the important organs from injury before we just assume that the person's fine. Our evaluation should focus on signs and symptoms that can include potentially life-threatening conditions. So even though I don't normally do things like take vital signs like blood pressure or pulse on the field, if somebody has an injury to the thorax and abdomen, I should be doing that. We want to monitor that breathing, circulation, and check for any indication of internal bleeding or shock. And it's not always easy to catch. As far as assessment history, we want to ask what caused the injury. So did they have a direct contact or a direct blow? Again, sometimes they don't know. The last student athlete that I had who had internal organ injury didn't realize that he had gotten hit there because he had landed on the ground. He didn't consider that to be a blow. So when we asked him what happened, he didn't know. What position were you in when the injury happened, and what positions are most comfortable now? When people are having a lot of internal organ pain, they tend to kind of curl up into a fetal position. What type of pain is it? Was it immediate, gradual, and where is it? Are they having difficulty breathing, so especially if they were struck in the chest? Do you feel faint, lightheaded, or nauseous? Do you have chest pain? Did you hear or feel a snap, crack, or pop in your chest if there was a blow to the chest? Is a person having muscle spasms? If they were hit low, was the bladder full or empty? And we may ask them to try to go to the bathroom to see if there's any bladder pain during urination. If so, that could be a kidney or a bladder injury. We'd also ask them how long has it been since you ate to try to get an idea of whether or not they have food in their stomach. And if it's more chest pain, we'll ask if there's a personal or family history of any heart problems or other diseases involving the abdomen or thorax. As far as assessment goes with observation, we're going to be wanting to watch them breathe. First of all, are they breathing? Usually they are. If they are they having any difficulty or pain or asymmetry with breathing? So both sides of the chest should move symmetrically or similarly when the person's having normal breathing. But if they're complaining of a lot of pain or if they're not able to breathe normally, then that would be an indication that something could be wrong. Does the thorax appear symmetrical? If somebody's had a bad rib injury, it might look like one side has a dent or divot or is moving more. Maybe it's coming out more just at one little segment than on the other side. We want to check for areas of discoloration, swelling, or deformity. It's not normal to see discoloration on the abdomen or on the thorax. If somebody has discoloration around their umbilicus or their belly button, that could be an indication of an intra-abdominal bleed, so that would be really bad. If somebody has bruising or swelling more on the flanks, so more on the outer part of the abdomen on the sides, then that would be considered to be swelling or bleeding outside the abdomen. We want to look at their body position. If they're unable to come out of the fetal position or they're unable to move comfortably, then that could be a good indication that they have an internal injury or they have something that is causing them to be in so much pain that they can't move normally. Are the abdominal muscles tight and guarded? Tight could mean that they're guarding pain, or it could mean that they have internal bleeding. Is the athlete holding or splinting a particular part? A lot of times people will just preferentially splint a damaged rib because it hurts. We want to monitor vital signs here. So again, I don't always do this with every injury, but definitely with an abdominal or thorax injury, we want to check this. So we want to check pulse, respiration, and blood pressure. A rapid weak pulse or drop in blood pressure is an indication of internal bleeding. If somebody's in a lot of pain, sometimes the blood pressure will be higher as well. So the most recent individual that I had spoken about earlier who had ended up, we found out later, rupturing his spleen, his blood pressure was really low, but we also had a blood pressure cuff that maybe wasn't working properly. It tends to run low anyways. It was an automatic one. So it's hard to say if he really was low or if it was just the blood pressure cuff. So it's important to have equipment that works properly as well. As far as assessment and palpation, this is the position we want somebody in when we're palpating. We want them on their back with their knees bent to help relax their abdomen. We'll check the thorax first. If they've had a blow to the thorax, we're going to put our hands on either side of their chest and kind of push in gently to check for symmetry and feel when they're breathing to check the chest wall movement, and also feeling for any areas of tenderness. we want to palpate the sternum and the ribs on the side. If this is a woman, we're going to avoid the breast area. So we can use the heel of our hand to palpate the sternum, and then the heels of our hand to palpate on either side of the ribs. We want to palpate along the ribs and intercostal spaces as well as the costochondral junctions. So the space between the ribs is called an intercostal space. So we want to see if we can distinguish between pain on the rib or pain in between the ribs, as well as where the ribs meet the cartilage closer to the sternum. That's the costochondral junction. As far as the abdomen, we're going to have the person lay on their back with their knees bent, arms at their side, and as relaxed as they can be. Their knees and hips will be flexed to relax the abdomen. We're going to start with the right upper quadrant, so they're right on the upper side, and we're going to try to see if we can identify the organs that are there, and we'll feel for a guarding tenderness and rigidity. Again, if they have tenderness and rigidity, that could be internal bleeding. Keeping in mind that they could have referred pain. Now, the individual that I saw that ended up having the ruptured spleen, when I palpated his spleen, it didn't hurt. It was kind of weird. Most of his pain was actually a little higher up, closer to his stomach. So it was more in here. His spleen would have been palpable more down here. But he had mono, so his spleen could have kind of spread out. But most of his guarding and pain was really more tucked up closer to where his stomach would have been, which was very weird. I will say, unless you're trained to do so, unless you're a physician or a physician assistant or a nurse practitioner and it's a part of your job, do not palpate genitals if they're injured. People can tell you if their genitals feel normal to them. They know. So I might ask somebody, if somebody has a scrotal injury, does it feel the same as the other side, or does it feel normal to you? I do not have to touch their genitals to know that. I don't have to visualize their genitals to know that. If somebody's genitals are swollen or bruised, they will tell you. So as we spoke about referred pain on the previous slide, we can get referred pain from different organs. So if somebody is having heart pain, they could have pain in the chest, or it can go down the left arm like that. If somebody is having pancreatic pain, they could have pain right here. If they have stomach pain, it's going to be more in here. Liver and gallbladder pain could be here, where the liver actually exists, and or here into the shoulder, which is kind of interesting. Somebody who's having pain with their appendix will have pain over a very specific spot in their abdomen. They'll have guarding, and the pain will be very specific. So the pain is going to be more about a halfway to maybe a quarter of the way to the umbilicus from the ASIS, which is right here. So we just kind of check those spots, and then we check about in this region. We'll push on them in that supine position, and if it hurts more when we let go, then that would be an indication that they could have something wrong with their appendix. Somebody could have ureter pain coming all through here. I had a rugby coach once come in to see me and told me he thought he hurt his hip flexor and he couldn't figure out what was going on. Tested his hip flexors, range of motion, strength, everything was fine. Dug a little deeper, and I ended up figuring out that he actually had a urinary tract infection, and he was getting referred pain through that hip flexor area from his ureter being infected, basically. Ovary pain could be kind of in here, pretty much anywhere in there. Kidney pain could be coming more through here. Bladder pain is going to be more there. So we can have some interesting referred pain patterns, but for the most part, people, we kind of think people tend to hurt over the actual organ area. But we want to be aware that sometimes people will have pain elsewhere, like with a heart attack, pain down the left arm. A lot of us already know that. As far as injuries to the thorax go, our first is rib contusion and or fracture. This picture down here is kind of funny. It's the best picture I could find. This is not a butt, although it kind of looks like it at first glance. This is actually somebody's arm over here, and this is their rib cage. So this is showing you a contusion of the rib, or bruising of the rib at least. Our mechanism for rib contusion or fracture, which we actually oftentimes will kind of just clump together because they generally tend to be kind of treated the same. Our mechanism here would be a blow to the rib cage that can either bruise the ribs, musculature, or result in a fracture. Usually rib fractures are not that severe unless it was a high velocity impact. Signs here would be very painful breathing. Even if there's no fracture, these are very painful, particularly if there's bruising to the muscles, the breathing is going to be painful. Our intercostal muscles, the muscles between the ribs, have a lot to do with our forced inspiration and expiration. So like if you sneeze, laugh, cough, breathe hard, those muscles have a lot to do with that type of motion, and so that can be really painful. The person's going to be point tender either over the rib or in the space between the ribs. They can have pain with rib compression. So if this individual was having pain over here, I wouldn't put my hand on that spot and push there, that's going to hurt, duh. But I would put my hand on the front and maybe the back side of the ribs and then press together to see if they then had pain here. So that would be a rib compression test, say for instance. So we do have some special tests for these types of injuries as well. They may have a limited ability to raise this arm up, and that could be painful. So they are likely to have limited range of motion with their arm movement. That's pretty normal with rib injuries. Our treatment here, if we do suspect a fracture, we may send them, try to send them for x-rays. When I was at UCSD, unless the person had an obvious deformity, the doctors usually didn't do x-rays anyways, because even if they have a fracture, it usually heals in about 3 to 4 weeks, and it's kind of the same if there's a contusion. There's really not very much difference. Both of these hurt a lot, so you just kind of have to be nice to the body part. As far as treatment, we'll do price and NSAIDs. If somebody wants like a wrap or something, they can wear one. I would recommend that somebody, if they're going to cough or sneeze, to brace that body part with their hands or a pillow to try to decrease their discomfort. We'll try to get them to rest and decrease activity. So again, even if they're breathing hard, it can be really painful. So running sometimes is a little tough. We can pad, wrap, and or brace that area for comfort or for return to play. And again, these are usually very painful. Another type of injury to the rib and thorax is a costal cartilage injury. So the costal cartilage refers to this cartilage that attaches the rib onto the sternum over here. And all of these blue parts are the costal cartilage. These are longer. And this is going to result, the costal cartilage injury is going to result from a blow to the rib cage, generally from the anterolateral aspect. So it's not going to be directly on the front. It's going to be a little off to the side. So this would be common if somebody fell on a football or a rugby ball, say for instance, while they were running with it, and the ball compressed their rib cage through here. That's really common. Signs here would be localized pain in the region of the costochondral junctions, pain with movement and difficulty breathing because, again, those ribs are meant to move when you're breathing. Point tenderness and possible deformity. Sometimes I'll feel a little bit of like a step off or bump there, which is somewhat unusual. That would be a good indication that somebody had this or a fracture, but usually a fracture is a little bit more jagged. This would feel more like just a bump. Treatment would be rest and immobilization, so like an ACE-RAP or just trying to get them not to move. And healing of this can take 1 to 2 months. So remember we talked about with the rib fracture, it was 3 to 4 weeks. For this, it's 1 to 2 months. So this can take longer to heal even than a fracture of the ribs. So these can be very painful. They're very nagging and annoying injuries. Another type of injury to the costal or to the rib thorax area is injury to the intercostal muscles. The intercostal muscles are the muscles between the ribs, and these are subject to contusions and strains. So a most common reason for for straining these muscles would be like if somebody was sick and they were coughing or sneezing a lot, or they just had one really massive sneeze, they could strain that muscle in between the ribs. These do occur most often from direct blows or sudden twisting of the trunk, though. So the direct blow would be if somebody had a contusion, and the sudden twisting would be more for this strain, muscle strain. Signs here would be pain on active motion, so oftentimes with trunk twisting or rotation, sometimes with forward and backward bend, but the rotational movements are usually more uncomfortable. They could have pain with inspiration or expiration, so inspiration, breathing in, expiration, breathing out. Again, that's the job of these muscles, so if they're, that's normal for them to have pain with those things. They could have pain with coughing, sneezing, or laughing. Again, all of those things are more forceful inspiration and expiration as well. Treatment here would be price. We can brace or wrap for comfort with daily activities, and they can do activity as their pain allows. But usually, again, just like with the contusions and the costal injuries, these can be pretty painful, and they can take up to a month to feel all the way better. Next, we'll talk about lung injuries. These can also occur from a blow to the chest. So just because somebody has a blow to the chest, we're not going to just automatically assume it's only their ribs. Sometimes these lung injuries can occur from somebody being sick or coughing really hard, and occasionally they can actually be something that just happens. With certain people, with certain body types, it's actually really easy for them to get what we call a spontaneous pneumothorax, where their lung will just randomly collapse. I've known a couple of people who've had that happen more than once. So this is an x-ray of a collapsed lung. So the lung is meant to be kind of like white shaded, and the side we just see black. So that would be an abnormal lung x-ray. With a pneumothorax, that's this picture. The cavity that the lung is supposed to sit in becomes filled with air for any number of reasons, but that filling with air changes the pressure in the cavity, and it causes the lung to not be able to expand. The lungs function on negative air pressure, so if you change the pressure within the cavity, it can cause issues with breathing in with the lungs. And again, those pneumothoraxes can be spontaneous, or it can be from a blow to the thorax. Tension pneumothorax is when that pneumothorax starts to get really bad, or it can happen if somebody has a wound to the chest. Either way, we're getting air in this lung where it shouldn't be, or in the chest wall where it shouldn't be. The lung on that side is not able to function, so the air that's coming in will actually cause everything to shift over, and that will displace the heart and the other lung and compress that. So that is definitely a medical emergency. We can see this sometimes with people if somebody's has this condition. What will happen, instead of their trachea being straight up and down, the trachea will actually start to shift to the side that the person still has their best lung function. So that would be a pretty scary indication that we need to call 911 right away. Hemothorax is when, instead of air getting into the cavity where it's not supposed to be, blood will get in there. So that could be from a penetrating wound like a gunshot or something like that, or it could be from a car accident with high velocity compression. These are less likely to happen with sports, but they could. So again, that's the hemothorax, so blood in the thorax. Signs here would be difficulty breathing, shortness of breath, and chest pain on the side of the injury. The person may be coughing up blood. They could be cyanotic due to a decrease in oxygen flow. So cyanotic means that they're turning blue, especially around the lips, nose, or eyes. They could potentially go into shock. Again, their body's not functioning normally. We're going to want to check the respiration rate, heart rate, and blood pressure. Our treatment would be to, these are all medical emergencies and they all require immediate medical attention. And we're going to want to call 911 as soon as we notice these things. But that tracheal shift is real scary. Next, we will discuss sudden death syndrome in athletes. Sudden death can be caused by a couple things, but generally speaking, most common causes are cardio or heart-related. So one common cause is hypertrophic cardiomyopathy, and we have a picture of that on the next slide. But it basically means that the heart muscle, especially in the left ventricle, gets or in the ventricles gets too large, and it causes the heart to not function properly, and people can die from this. So it's an abnormal thickening of that cardiac muscle. Another type of condition that can cause cardiac abnormalities is called Marfan syndrome, and that's an abnormality in connective tissue that can result in weak blood vessels. At least that's how it relates to the heart. This syndrome has other symptoms as well. Some people can have other cardiac abnormalities, like maybe the heart just didn't form properly when they were in utero, so they could have be at a higher risk for death from sports. Non-cardiac causes for sudden death include drugs and alcohol, intracranial bleeding, so when the brain bleeds, or second impact syndrome could be a possibility, or obstructive respiratory disease. Unfortunately, as far as sudden death syndrome in athletes, our first and most common sign is death. So as far as hypertrophic cardiomyopathy, it's kind of a blessing if people actually do catch this before, or if their condition is caught before they basically die or go into cardiac arrest, because usually it's not caught. It doesn't show up on regular exams. Somebody would have to have an EKG and an echocardiogram to know that they had this. Some people might exhibit chest pain, heart palpitations, syncope or fainting with exercise, nausea, profuse sweating, shortness of breath, malaise, that's that icky feeling you get when you're getting sick, and or fever. So we usually will ask about these things when we're doing a health history and a pre-participation physical exam. And if somebody is reporting any of these symptoms, we'll want them to make sure that they get checked out, that their heart is examined properly to make sure that they're not at a risk for sudden death. Treatment, immediate medical attention is necessary. This is a life-threatening condition. Obviously, sudden death sounds life-threatening. But if somebody all of a sudden passes out and they're non-responsive, that's the situation where we need to get an AED. And it honestly, at that point, it doesn't particularly matter what of these things is causing it. The main thing is that we need to perform life-saving measures and call 911. As far as preventing sudden death in athletes, proper counseling and screening are really critical for early identification and prevention of sudden death. So our screening questions in our health history should address a history of heart murmurs, chest pain during activity, periods of fainting during exercise, a family history of heart disease, especially under 50. If the individual has a strong family history of heart disease, but the people in their family don't have issues with it until they're in their 60s or 70s, that's actually pretty common, so it's less concerning. If they have a known thickening of the heart or a history of Marfan syndrome. So this picture right here is a picture of hypertrophic cardiomyopathy, and this is a normal heart. So you can see that the heart muscle gets really thick and kind of boggy, and the heart just doesn't pump as effectively. It's actually a normal adaptation to exercise to have the left ventricle get slightly more muscular, but the right ventricle should still look similar size, and also the left ventricle shouldn't be this big. It won't get that thick, it'll just get slightly hypertrophied. So somebody might have an echocardiogram that shows that they have slight thickening, and that would be normal, but it shouldn't be to this extent. These photos over here, this is a picture of somebody getting an EKG with 12-lead EKG, so they have all these little electrodes on them that are going to sense their heart rhythm and heart electrical activity. And this is a picture of an echocardiogram, so it's an ultrasound of the heart, and that's the only way we can truly know what's going on with the structure. The EKG will suggest things that could be different about the structure of the heart, because if there's a structural difference, sometimes the electrical impulses aren't transmitted properly. But if we really want to know what the heart looks like and know if the person has thickening of the heart muscle walls, then they're going to need an echocardiogram. This particular individual is an example of Marfan syndrome. So he's a pretty classic example. He's tall, thin, has very long limbs for his size. He has poor vision. That's another thing that goes along with Marfan's oftentimes, because those individuals will have a weak connective tissue in the eye as well. So they won't be able to necessarily focus as well, because those muscles that help them focus are weaker as well. So we have a couple different screening tools we can use for Marfan's. Obviously, you can't just look at somebody and say, oh, you're tall and skinny, you have Marfan's. So a couple different things we do for screening is we might check to see if their wingspan or their fingertip to fingertip length, if they're completely stretched out side to side, is taller than their height. If their wingspan is taller than their total height, then that's one screening tool. Another easier screening tool is if we have somebody take their fingers and try to put them around their wrist, and if they can overlap their pinky and their thumb finger very easily, then that's also an indication that they have very long bones and should be screened for Marfan's. So for me, I have very long fingers and I can't quite touch with my thumb and pinky. But if somebody's overlapping quite a bit, then that would be a screening tool that would help us determine that maybe that person needs some follow-up with a doctor. Again, as far as cardiac screenings, we want people to get an electrocardiogram or an EKG, sometimes known as an ECG, same thing, and an echocardiogram to determine whatever their existing pathology is or whatever their problem is. Another less life-threatening condition that is actually pretty painful, though, is an injury to the abdominal wall. So abdominal muscle strains can be really painful. We use our abdominal muscles for stabilization in most positions other than laying down, so that they do tend to be pretty painful. This particular gentleman has ruptured one side of his rectus abdominis, it looks like to me. Our mechanism here would be it's a result of sudden twisting, reaching of the trunk, and that could cause tearing of the abdominal musculature. I've also had some individuals cause abdominal strains from doing full sit-ups on a exercise ball, because they came back really far into extension with the trunk and then came up. They weren't quite strong enough to handle that exercise, and they caused abdominal muscle strain. As far as signs here, it's very painful to move, laugh, breathe deep, and contract their abdominal muscles. These, again, are pretty painful. Treatment would be ice rest, and when they can tolerate them, isometric core exercises. So this would be the TA contractions or working our way up into planks, but doing crunches would not be recommended. As far as contusions of the abdominal wall, a mechanism here would be some kind of compressive force, like an elbow or knee or a head or helmet to the abdomen. Signs here that may cause a hematoma to develop under the muscle tissue, but it would be a distinct area. It wouldn't be a large area. They wouldn't be complaining of any systemic types of issues, like as if they had internal bleeding. The swelling might cause pain and tightness in the region, but they shouldn't have changes in their respiration, blood pressure, or heart rate with this. Treatment would be cold pack and compression as needed, and being sure to check for signs of internal injuries. Exercises should be kept pain-free. The next type of injury that we'll discuss is hernia. Causes of hernia would be a protrusion of the abdominal viscera through a portion of the abdominal wall. Basically, you get a separation of the abdominal musculature, and then you'll get a little portion of the intestines that comes sticking out of it, like in this picture right here. it sounds in some ways worse than it maybe is. These oftentimes will be repaired, but somebody having their abdominal viscera sticking out of their muscle and only being contained within their skin sounds a little weird, but sometimes it does happen. This particular picture is a picture of an inguinal hernia. So our inguinal line is a line that runs from our pubic bone up to our ASIS and our hip. And so this hernia happens to be on that line, so that would be an inguinal hernia. This hernia is an umbilical hernia, and she most likely got that from being pregnant. You can kind of tell by just looking at her skin that she's recently delivered a baby. She also has what we call linea nigra from hormonal changes from pregnancy. So those are two different kinds of hernias. Men can get umbilical hernias as well. Women don't as commonly get the inguinal hernias, though. Those are more common in men. The inguinal hernias are the reason that your doctor might have you turn your head and cough while they're palpating your scrotum when you go to get a checkup at the doctor, because oftentimes the inguinal hernias actually don't come out here. They'll come out into the scrotal sac because that's an area of separation within the muscle already. So sometimes people don't necessarily know that they have a hernia. That's possible. If it's coming down into the scrotum, they just might think their scrotum is sore or swollen for some reason. Signs here would be an acquired hernia occurs when a natural weakness is further aggravated by a direct blow or strain. So could be the person got hit there. That's not super common. More commonly it would be somebody straining to lift something heavy, or they could have been straining to go to the bathroom, or it could be more of a chronic strain from pregnancy. Your muscles split and expand, and they become weaker in the center, so it makes it more difficult as far as trying to keep everything together as it should be. The person could have a history of a direct blow to the groin area or prolonged discomfort. They may have a superficial protrusion with pain increasing with coughing and bearing down. So when somebody has a hernia, most of the time, if they cough or bear down like they're going to go poop, they will feel increased discomfort. Most physicians will prefer an athlete to refrain from hard physical activity until these are surgically repaired. So if somebody has a hernia, we're gonna want to keep them out of activity until their hernia is repaired. Next, we'll talk about spleen rupture. So this is a picture of where our spleen is meant to sit underneath our ribs. Sometimes if we get the person a little bit extended, we might be able to get our fingers under the ribs to be able to feel that's the lower border of the spleen. So not always quite that high, but the spleen shouldn't be sticking out well below the ribs like this. If somebody has a spleen rupture, it's oftentimes a result of a direct blow. Maybe with that slight extension, maybe somebody caught them under the ribs with an elbow, or when I was little, one of my friends got herself under the ribs with her bike handle because she tried to ride her bike off a picnic table. Infectious mononucleosis will increase the risk of this because the spleen becomes enlarged. It can become quite enlarged actually and stick out below the ribs there. So the spleen is not as protected in that position. Our signs here would be a history of a direct blow. It doesn't have to be a hit. Like I said earlier, or in an earlier different lecture, I had a student athlete who I found out later had mono, and he had laid out, he had fallen on the ground in a stretched out position, and that was a direct blow that ruptured his spleen. The person could have signs of shock, abdominal rigidity, nausea, and or vomiting. They could have what we call Care's sign. So that would be pain down the left arm. So somebody can have pain down the left arm that is not a heart attack. This pain follows a slightly different pathway. I wouldn't necessarily expect you to know the difference, but if somebody has a history of a direct blow underneath the rib cage and they're having pain down the left arm, we would think more spleen rupture. If they had a history of heart issues or they were having chest pain and pain down the left arm, then we'd be more concerned for a cardiac event or heart attack. Spleen ruptures can cause severe internal bleeding, which can be life-threatening because the spleen's job is to make red blood cells. So there's a lot of blood flow and blood exchange in that area already, so when it's damaged, it tends to bleed a lot. Sometimes the internal bleeding can be delayed, but it will worsen if the person is moved a lot. Treatment here, conservative treatment would be 1 week of hospitalization and then gradual return to play. And that just, I think, depends on how bad the surgery or how bad the injury is, if they need surgery or not. Surgery would be a 3-month recovery. As far as if somebody needs to have their spleen removed, they'll do a 6-month removal from activity and then they can return later. Even though the spleen's main job is to make red blood cells, that's not the only mechanism by which we make red blood cells. The long bones of the body also make red blood cells, so if the spleen needs to be removed, our body can compensate, but I think it takes a little while for it to kind of catch up and start replacing those blood cell production elsewhere. Another type of organ injury that we can get, or organ illness we can get, is appendicitis. So the appendix is a little tiny tail. So if we look at the colon down here, the large intestine, the appendix is a little tiny tail that comes off the bottom of that intestine. And it's an area that is likely to have a lot of bacteria buildup. So if somebody gets an appendicitis, the cause is they're getting an inflammation of the appendix. And this can be acute or chronic. It can be a result of a blockage, lymphatic swelling, or a tumor. Early stages of appendicitis will present as a gastric complaint. They'll feel like their stomach's kind of upset. And then gradually the symptoms will get worse. If the appendicitis is left and the person is not treated, it can rupture into the abdominal cavity, causing peritonitis, which is an infection of the lining of the abdomen, which is really scary. People can die from that. When I was at University of the Pacific, one of our soccer players, the soccer goalie, actually started the game with her stomach kind of feeling upset, and by halftime she was curled up in the fetal position on one of our treatment tables, and it turns out she actually had an appendicitis. And she played for a whole half of a soccer game with appendicitis. So sometimes it doesn't start off being that bad, but then it will gradually get worse. I will say that my mom actually recently was diagnosed with appendiceal cancer, and at first it started off seeming like chronic appendicitis, and she had pain over that McBurney's point, so that point that's about a half to a quarter, somewhere in there between that ASIS and the belly button. She had pain in that region, and it took her kind of a long time to figure out what it was from. She thought it may have been ovarian pain or something like that. So, we want to pay attention to these. Usually the pain with this is going to be mild to severe pain in the lower abdomen. The person could feel nauseous, they could be vomiting and have a slight fever. And the pain may localize in the lower right abdomen at McBurney's point. With appendicitis, the way this hurts is kind of specific. If they are having pain at McBurney's point, if we push on that spot and then let go, then the letting go is what causes more pain usually with this one versus the pushing. So that's a fairly strong indication that the person has appendicitis. They don't have to have that pain to have appendicitis, but if they have pain like that, that would be a likelihood that they have this. As far as treatment, usually surgery is necessary because we don't want to cause peritonitis. If the person is partially ruptured at the appendix and then it seals up again, then they may not need surgery. Sometimes that happens as well. And last but not least, we have scrotal and testicular injuries. Our mechanism here would be a result of a blunt trauma to the scrotum. This can cause a contusion, just the regular bruise, a rupture of the scrotum or testicle, or testicular torsion. The way the testicle sits in the scrotum, there are basically dangles. The testicle dangles into the scrotum, and it's suspended by basically like a tube or a string, you can think of it. And sometimes if somebody gets hit hard enough, the testicle can twist and it causes damage uh, to that part of the organ that's suspending it. So that would be testicular torsion. I have had a couple of student athletes who've had pretty severe testicular injuries actually. Most of the time they're just a contusion, but they can be severe, and sometimes it can be hard to tell the difference. Our signs here could be hemorrhaging or bleeding in the area of bruising, edema. The swelling will be severe if there's rupture or torsion, muscle spasm, oftentimes in the abdominal muscles, and severe pain. This could be disabling. This can cause nausea, and it's disabling and painful condition, even if they didn't get hit that hard. It's a very sensitive area. Our treatment here would be to place the athlete on their side with their knees to their chest. This makes me really giggle inside just a little bit because in 20 years, I have never had to tell somebody that got hit in the groin to curl up into a little ball because they were in pain. It's just something that people do automatically. We can apply a cold pack until the pain subsides, but if the pain persists after 15 to 20 minutes, they should go see the doctor. Keep in mind too that with a cold pack, make sure that if they're icing the actual scrotum, that there's something between the cold pack and the skin. That skin is very thin, and you don't want to cause frostbite. If the pain is persisting after 15 to 20 minutes, the doctor will probably want to ultrasound the testicle to check the extent of the damage. I had a rugby player, maybe my second to last year at UCSD, who was struck in the scrotum in one of the last parts of practice, and somebody just got him with their shoulder, but it wasn't that bad. I mean, he walked off the field. He didn't even come see me for ice. He just walked off and went back to his room. And then the next day he came into the athletic training room and said, I got hit last night in practice and I'm still having a lot of pain. I said, okay, well, I don't necessarily need to visually inspect the area, but does it look swollen to you? And he goes, oh yeah, it's very swollen. And so I was concerned about the fact that he could have either ruptured his testicle or gotten some testicular torsion. So, and again, I didn't need to visualize this. He knew his own scrotum way better than I did. So I just sent him to student health because that's what the way his insurance worked. He had to go there first. And at student health, they ultrasounded his testicle. They said that they thought he possibly had testicular torsion and he needed to have surgery. So he actually went and was scheduled for a surgery that day. And he went into the surgery thinking that he just had torsion and they were going to be able to fix it and all this other stuff. And one of the questions they asked when he went into surgery is, if we have to remove your testicle, would you like an implant? And he said no. So he comes out of the surgery, and it turns out he didn't have testicular torsion. He had ruptured his testicle and it was beyond repair. So they actually had to remove it. He was, I think, 21, 22. So it was unfortunate that he decided he did not want a testicular implant because now he's only down to one testicle. And I think he was okay with that. I mean, his Facebook status after he had surgery was lost my marbles. So I don't think he was super sensitive about it. But, if any of you ever have to go in for testicular surgery, just make sure to check the box saying that if you care about how those things look, that you want an implant, because sometimes stuff happens. With that particular individual, because he had loss of a paired organ, he was not allowed to play for the team for a while, and we talked about him a little bit during our information about disqualification. He actually did end up returning to rugby. He, signed a statement saying that he understood that he was being medically advised not to, since he had lost a paired organ. He was advised to bank some sperm in case he wanted to have kids, just in case the other testicle became damaged. And eventually he was cleared to play, but he stopped playing for about 6 months. So these can be serious. Usually they're not. But again, if the pain is still there past 15 to 20 minutes, they'll want to go to the doctor. The other thing with this is I always ask people to try to urinate for me and let me know if they see blood in their urine as well, just because that could be a sign of something serious as well. But usually it's the swelling and hemorrhaging that would give us a really good clue that somebody's having a big problem. And that is the end of this chapter.